Hi, I'm Dr. Hannah Trainer, Principal Clinical Psychologist.
And I'm Dr. Helen Nichols, Principal Clinical Psychologist.
And we work in the Liverpool Stroke Recovery Partnership team. As clinical psychologists in stroke, we are healthcare professionals who specialise in the assessment, formulation and treatment of psychological difficulties following stroke. This includes specialist neuropsychological assessment and management of cognitive impairment. The aim of this brief training video is to identify the psychological impact stroke can have and the emotional effects commonly experienced by stroke survivors, including difficulties with mood, anxiety and adjustment. We'll also provide advice on strategies and skills you can use within your role to enhance a person's coping and ability to adapt to life after stroke, including tips for managing mood and anxiety in the moment. Access to psychology can vary from team to team, but national clinical guidelines recommend routine assessment and management of mood and cognition after stroke in both acute and community rehabilitation services. Mood disturbance following a stroke is very common and typically presents as low mood or anxiety. During the first 2 years after stroke, up to 30% of survivors will develop and struggle with depression, known as post-stroke depression. Research has demonstrated that mood disturbance is associated with higher rates of mortality, long-term disability, readmission to hospital, suicide, higher use of healthcare services, poorer recovery and social functioning, and increased dependency. Additionally, the majority of stroke survivors will experience some form of cognitive deficit, and up to 75% will have significant cognitive impairment. This might include problems with memory, attention, language and perception, and organisation of movement and thoughts. This can further complicate the process of adjustment and challenge the management of mood and anxiety.
Clearly, there is a breadth of ways stroke can impact on a person's life, many of which are shown here, but there are also many others not listed. The multitude of difficulties illustrated are also unlikely to be experienced alone, independently, and more often than not in tandem and impact many other areas, creating unhelpful patterns of thoughts, feelings and behaviours. These patterns can be hard to break out of, and it can be hard to recognise when they are happening. It is critical, therefore, to understand all factors involved when thinking about the management and treatment of the person. In terms of psychological factors, although we see statistics such as 75% experience low mood, people invariably differ with what their low mood is about for them, how they perceive their situation, their pre-existing coping mechanisms, and how they make sense of what's happening to them in their lives. We all have our areas of expertise within our disciplines, but inevitably we will all see and need to support in some way many of these different areas of difficulty with our patients. As with any major life event, a stroke can be a traumatic and life-altering experience with many significant short or long-term impacts. The majority of patients to some degree will experience emotional changes which will affect not only their personal relationships but also their confidence, self-esteem and general sense of self-worth. The way a person used to live pre-stroke compared to post-stroke, loss of employment, finances and changes their roles within their family system are all key areas which can create a lot of worry and uncertainty for a stroke survivor. Thinking more about mood, there are two main causes for emotional changes following a stroke. The first is a reactive change. What we mean by this is a person having an emotional reaction to the event of having a stroke and/or to the resulting effects of the stroke. For example, experiencing communication difficulties may mean a person is unable to express themselves in their usual ways. This may cause them to react to the situation by experiencing a range of emotions such as frustration, anger, low mood, despondency, etc. The mood change is not a result of the stroke, but a reaction to it. The second cause for emotional changes is an organic change. What we mean by this is the stroke changes how the brain responds to things. For example, a frontal lobe damage can occasionally cause someone to have trouble empathizing with other people. You may also see a person experience post-stroke emotionalism. This is typically seen by increased episodes of crying and feeling upset. A person may state something like, "I don't know why I'm crying, this is not something that is normally upsetting for me." Episodes of crying can come and go very quickly, sometimes with multiple brief crying episodes in the space of one appointment. It can be very difficult to cope with the emotions a person has after a stroke. But if they don't acknowledge the way they're feeling and find things that can help them to cope with it, these emotions become overwhelming and can lead to problems. Anyone who suffers a major loss will go through a range of emotions as they try to come to terms with what's happened. Feelings of shock, denial, anger, grief and guilt are normal when you're faced with such a major life-changing event. Loss for stroke patients could be loss of independence, for example with driving, could be physical changes and losses of mobility, vision, loss of identity, day-to-day routines, relationships, self-esteem, the list can go on. But ultimately, any form of loss can trigger a grief reaction. People don't necessarily have to start at the beginning of the curve. They can move forward and backwards quite fluidly. The curve can be useful to help identify where someone is at and when they start to experience emotional changes.
Here are some tips and ideas on how you can assess and ask about psychological well-being, and some strategies for how to support someone in conversation about their emotional state and management. If you suspect or identify that someone is struggling with their psychological well-being, it can be useful to complete a formal assessment to gain a baseline. You can use the Patient Health Questionnaire, also known as the PHQ-9, as a guide to measure symptoms of low mood and depression, and the General Anxiety Disorder Questionnaire, the GAD-7, to measure symptoms of worry and anxiety. These are commonly used in psychological services, but can be administered by any professional if there are concerns raised around psychological well-being. It's important to hold in mind that these measures aren't adapted to account for effects of stroke, including emotionalism, fatigue, and cognitive impairment. Therefore, when interpreting scores, it's important to bear this in mind, as a high score might not necessarily indicate that a person is just struggling with their low mood and anxiety. These questionnaires can be useful to repeat further down the line in rehab, to either highlight improvements for individuals or identify if longer-term support may be indicated, and suggestions can then be made for signposting and referral to local services. Sometimes it's not always possible or advisable to complete formal measures, but it's still important to check in to see how somebody is coping and is managing their well-being. Some questions to consider incorporating into your own assessments and conversations may include inquiring how things are for them at the moment. The experience of having a stroke and adjusting is difficult, so you may notice this and be curious about how they've been managing. You might have identified that someone is facing lots of stressors, for instance, waiting for further investigations and results, facing financial hardship and difficulties and delays in navigating the benefit system, or challenges in their relationships. So you may want to ask about how they feel they are coping with these. Or if you're aware of adversity they've faced in the past, you might inquire about how they've managed and if anything helped or supported them through these times. Can you identify with them any times they feel better or not as bad, and what helps in these moments? If someone is struggling to identify difficulties from their own perspective, it can also be helpful to ask them to think about what family or friends may have noticed is different since the stroke, and what they might say the person is struggling with and how they're managing. During these conversations, it's important to listen and normalise their experiences. Asking and talking about how someone is feeling and managing can sometimes make them become a bit upset, especially if they felt avoidant or ashamed of their feelings. But often stroke survivors report feeling relieved that they've been asked. It normalises their experience and starts to challenge beliefs they may have developed about being different, going mad, or losing it since a stroke. Large amounts of research demonstrate that listening alone can improve well-being and reduce distress. However, it also shows that the quality of listening is equally as important. Therefore, providing a safe and private place to talk is essential. Talking in a busy ward environment or a chaotic home is not just overstimulating, but can cause a person to be hesitant and cautious about what they do and don't say. If possible, find a quieter spot, ask the person if you can talk privately, and invite friends and family back later on in your session. During the conversation, summarise what they say and clarify what they mean if you're unsure. Try and resist offering too much opinion or direction, and instead try and guide the person in discovering their own solutions. Ask open questions and give them space and time to think and reflect on the things they can do to support themselves. Don't forget that the basics are essential in maintaining a positive sense of well-being, and are often the first things to stop and change when we're distressed. Explore factors such as keeping a routine, including sleep, diet and movement, and how they can maintain a sense of this during their recovery. think together about activities they enjoy, whilst being aware of their limits and how they might be adapted. Also, the power of psychoeducation shouldn't be underestimated. Sharing psychoeducation about common emotional changes post-stroke helps to normalise the experience while building understanding and insight into difficulties. Awareness can help with regulating emotions and developing kindness and compassion towards themselves, removing some of the pressure and guilt that is often reported by stroke survivors. This in turn can help support engagement in rehab and enhance overall recovery.
Anxiety can be a difficult but common experience for people after a stroke. There are various strategies that can be implemented to support a person to cope with this. For example, you can introduce relaxation to a person by suggesting that there are various techniques which can help them calm the bodily responses which are commonly experienced alongside anxiety. For example, you could say, anxiety can be unpleasant to experience. We have some techniques that can help our body to calm down and to relax. Would you like to try this? You can also use mindfulness exercises, grounding techniques, and deep breathing. Here we have just a short video just to give an example of a breathing exercise. It's called the box breathing exercise, and it's quite simple and quick and effective to use with people in the moment during sessions.
So Hannah, we're going to practice a short, simple breathing exercise today, because we know when people feel anxious that their breathing becomes faster and it becomes shorter, and it's usually up here in the top part of the chest. So this simple breathing exercise is designed just to deepen the breath and just slow it down to create a sense of balance and calm. The breathing exercise we chose is the box breathing exercise. Do you have any questions about that before we start today?
Yeah.
Okay. So just before we start, if you'd like to uncross your legs and just have your feet flat on the ground and just make sure that you're sat comfortable in your chair. And as just a reminder, the box breathing exercise is just 4-second inhale, 4-second hold, 4-second exhale, and a 4-second hold. And to help with that, we just draw a box as we go. Are you ready to begin?
Yeah.
Okay, we'll start first with an exhale, and then we'll inhale, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, and hold, 2, 3, 4, inhale, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, and hold, 2, 3, 4. And you continue with that pattern, you will start to feel like breathing slows, find a balance, that sense of calm, and the anxiety will start to reduce.
As we know, anxiety is a fear-based response which occurs due to the brain responding to a perceived threat. This could be a worry about something that might happen, such as a worry about falling during a mobility exercise, or it could be an actual threat happening to a person in real time, such as someone being threatening to you. Whether it is a real or a perceived potential threat, what we know happens is in either situation the brain responds the same way, as it thinks that you are unsafe. What we need to do is show the person, show the brain, that they are safe and be reassured that nothing bad will happen. One way to do this is to help them have successful experiences from which they can learn and build their confidence. Setting realistic, graded goals can help achieve this. You can set the scene for this by stating something like, "Let's see how we get on with this. Shall we just give it a try and see it as an experiment?" After the activity, asking the person how they think it went, what helped, is there anything they would do differently next time, can help build autonomy, whilst also providing the evidence needed to reassure and reduce any worry about the tasks at hand. Given the nature of common difficulties that are experienced after a stroke, adapting our approach as therapists is often needed. For example, considering a person's insight into their difficulties, thinking about, do you need to focus on building this first before working on rehabilitation? Other adaptations may include providing written or other visual information to support with memory or communication difficulties, allowing regular breaks to accommodate for reduced attention or post-stroke fatigue, or perhaps if you were considering using relaxation strategies to aid reduction of anxiety pre or post rehabilitation, you may want to be selective with the exercise you choose depending on the difficulties that a person presents with. For instance, a progressive muscle relaxation exercise will often need adapting for those who have sensory loss or physical changes, as often sensory change can mean that too much body focus is unhelpful, so it is important to use your own judgment, knowledge and understanding of the patient to assess whether these are appropriate to use in the moment. In summary, some key points to hold in mind from this presentation are: changes of mood, whether reactive or organic in nature, are normal following stroke. It can be helpful to allow space during your sessions for patients to express their emotion about their experiences and for you to offer emotional support. If you're concerned or wanting to monitor mood, then you could consider completing some of the outcome measures discussed here today. There are lots of helpful strategies that you can use with patients to help them to cope with emotional changes. For example, completing a relaxation, breathing exercise that could be demonstrated, mindfulness or grounding techniques before an intervention if a patient appears anxious. And finally, if psychology is available, consider referring for support if mood changes are long-lasting or significantly impacting on engagement day-to-day, activity, rehabilitation, or affecting personal relationships. We hope that this has been helpful for you, and thank you for listening.